large small cell lung cancer that I see, we do diagnoses for this, but we don't operate on them, is less than 1 centimeter in size, but their lymph nodes are 5 centimeters in size, and they have metastases to their brain before you even get a chance to diagnose them. So they're aggressive. The only treatment for them is chemotherapy and radiation, and hope for the best. Now, non-small cell lung cancer, we can actually do something about. And there's a whole different number of types of it: bronchoalveolar, adenocarcinoma, squamous cell carcinoma, large cell carcinoma. There's a whole lot of subtypes. The subtypes are basically define how it looks under the microscope and how it behaves in the patient. And it goes from the least aggressive to the most aggressive. Bronchoalveolar type of carcinoma doesn't even, is very hard to define, doesn't even form a nodule, for instance. And it probably takes about 5-6 years without any treatment, surgery, chemotherapy, anything, to even grow a little bit. It's very slow growing, very nicely behaved. If anybody was to choose to have lung cancer, this is the one to get. And it goes down to large cell carcinoma, which is treatable, but it behaves aggressively. And so it's something that we have to know about. Next slide, please. So, when do we catch the lung cancer? Typically, by accident. That's how it goes. Usually, people walk around with some symptoms, no symptoms. They don't feel like going to their doctor. People in Brooklyn are notorious for coming. They come to my office. When's the last time you saw a doctor? 7 years ago. Just didn't feel like going, and I felt fine. I was working, doing my thing. It's usually by accident. It's usually done for something else. I caught a guy with lung cancer who came in for an appendectomy. He had appendicitis, came into the ER, and when they did a CAT scan of his belly to look for the appendicitis, part of the CAT scan showed a little bit of lung with a tumor in it. And it was early stage. After he had his appendicitis, he got an operation and cured him of his lung cancer. He got lucky, because he could have just as easily been walking around with symptom-free, and with that cancer growing until it was too late. So the most common ones that we catch are the early stage ones, where people have no symptoms, there's no real problems that they're complaining of, and they come in for a CAT scan of something else, and we find the lung nodule. The late stage ones are the ones where it's not a lung nodule, where it's already spread, there's metastasis to the lymph nodes, there's metastasis to the brain, there's metastasis outside of the lung into the space where the lung sits in the chest wall and creating some fluid. So all of these things, that's the most common one we unfortunately see. That's what gives people the symptoms. When they become noticeably short of breath, when they start coughing up blood, when the tumor itself erodes into an artery or a vein and causes bleeding to come up into the airway and they start coughing it up. The intermediate stage cancers we don't often see, because usually people present by accident early or too late. Next slide, please. So going back to the whole lung nodules phenomenon, and this is my expertise. This is what I do. Most of the time, these lung nodules that don't look suspicious, that I'm not concerned about, we watch and wait. It's a perfectly reasonable thing to do. What we do is we get another CAT scan in 2 to 3 months and wait and see. If the CAT scan in 2 or 3 months shows that the lung nodule hasn't increased in size and hasn't done anything to make itself declare itself in any way, then what do? We get another CAT scan, this time in 6 months. And if it still doesn't change in size, next one's a year later, and so on and so forth. And after 3 years or so, if that thing doesn't change in size, we leave it alone. Stop getting CAT scans. Safe to say, it's not a tumor. Sometimes you get a CAT scan in 2 to 3 months, and the nodule's increased a little bit in size. When it increases a little bit in size, that's when we start to think about something bad being there, and we go after it. Now, biopsy. We sometimes biopsy suspicious lesions, suspicious nodules. We don't really biopsy things that we don't think are suspicious unless there is any kind of declaration of growth, and we can't. And when we can't figure that's for that middle, going back to that other slide where I had that middle statement in the middle where I say to people, well, you know, it could be a lung cancer, it might not be. We don't know for sure. We'll do a biopsy. And the biopsies we do, you know, we usually get it's on the CAT scan table. We have our colleagues in radiology put a needle in under local anesthetic and suck some cells out of the tumor, and we look at it. Now those biopsies, that's one way to do a biopsy. Sometimes the tumor is in a location where we can't easily just stick a needle into it. So sometimes you have to do surgery to do a biopsy, and that usually is a minimally invasive procedure where we go in and just take out that little tiny piece of lung with the nodule in it and see what it is. Next slide. So something suspicious. So this is the meat of the talk here. So if you have a suspicious lung nodule, and we all think it's cancer, and we start going down the cancer route, we have to stage it. What does stage mean? Staging is how extensive the disease is. Did it spread? Is it just the isolated nodule there? Has it gone out? Has it spread to the lymph nodes? Has it spread to other areas in the body? Okay? Very important to know these things because sometimes it'll change the way we treat it. Okay? So one thing we do is a PET CT. It's a CAT scan that's specialized where you're injected with a radioactive sugar. And it's cells in the body like to use sugar. That's how our metabolism works. Certain cells in the body use more sugar than others. The heart, always beating, always working hard, uses a lot of sugar. So when we inject sugar into those patients, and we get the PET CT with the CAT scan, that heart lights up like a Christmas tree, and we know that. Doesn't mean it's cancer. The brain likes to use a lot of sugar. In fact, it uses sugar exclusively. And so the brain lights up. So when the brain lights up like that, we can't see if there's metastases to the brain. We can't see if there's any spread of the brain. So we have to do the other test, the MRI of the brain as well. Basically, the cancer itself is a hard-working thing. Those cells in the cancer, they're constantly growing, they're constantly dividing, they use a lot of sugar. So they light up very, very brightly on this scan. And it helps us not only confirm the diagnosis, but it also helps to look for things that we didn't necessarily see on the CAT scan that are lighting up. And that tells you that there's likely a spread of the cancer to those areas. What do I tell people then? Surgery is the only chance to cure. A chance to cut is a chance to cure. Unfortunately, that is the way lung cancer is treated these days, and the only chance at curing it is by having an operation that takes out the lung cancer and all of the possible areas of spread that it's associated with. So, in preparing for these two things, not only do we do the staging, we like to look at people's hearts, we like to look at people's lungs. We want to make sure that you're going to be able to tolerate the operation, and we want to make sure that whatever part of the lung that we take out, you're not going to miss it, meaning that you're going to be able to still function and breathe normally. Not everybody, after removing lungs, is going to be able to run a marathon, but our goal is to not make them crippled and on a ventilator for the rest of their lives. So that's why we test the lung function to see how good people's pulmonary reserve is. And usually, when it's a suspicious nodule, we go for surgery right away. There's no need for a biopsy. Biopsy just delays the operation, delays the treatment, and has its own complications as well. Next slide, please. So, what do we mean by staging? What I touched on earlier, and I'm going to go into a little more detail about. So, the lung cancer can spread in several different ways. Local spread. What we call local spread is where the tumor itself starts to spread within the area where the tumor is. Forms little satellite nodules, starts creeping along the surfaces of the airways and things like that, and sort of spreading locally. That we're not so concerned about. Cancers grow. That's how they spread. They spread locally. Regional spread refers to all of these lymph nodes. If you look at the anatomy here, here's the windpipe. and here's the airways going to the left and the right side. And there are all these lymph nodes there that I talked about before. So just as they clean up whatever fluid and debris you inhale in the lungs, it also, the cancer also goes to these lymph nodes. It starts to spread to these first. If there was a tumor here, it would spread to the ones that are closest first, then subsequently go to the ones that are farther away. And once they get to the ones that are farther away, we say that the horse is out of the barn already. That's when we could say that we can't really operate, because taking out the tumor without being able to control whatever's gone into the lymph nodes is not going to help anybody. And then there's the distant spread. Distant spread is obvious. Once it spreads to the brain or the bone or anywhere else, we want to know this, because we can't do surgery because it's not going to be helpful to the patient. Next slide, please. The staging system for lung cancer over the last 20 years has gotten unbelievably complicated. What started out as stage 1, 2, 3, 4, where the lung cancer is just like one cancer in one area, and then it spread to the lymph nodes, and then spread regionally, and then spread distantly, became a very complicated thing because of the amount of studying we've done of lung cancer. So we've gotten a good idea of which patients do well, which patients can be cured, which patients need chemotherapy first, which patients need radiation and chemotherapy first, which patients need chemotherapy after. And it's a very complicated process, but to sum it up, basically, it's still stage 1 through 4. And stage 1 is basically small tumors that are confined to the lung, and basically these are the best ones. These are the ones that they haven't spread anywhere, and they're small, and they haven't caused any harm. Now, stage 2 are tumors that are slightly larger, and they've spread to lymph nodes that are right next to them, but haven't spread to lymph nodes that are further away in the middle. Stage 3, now we're starting to get to the point where we can't do anything for you surgically, is larger tumors that spread to those lymph nodes in the middle, all along the trachea, all along the windpipe, and those also include tumors that are invading things that we can't surgically remove. Tumors that locally invade a rib, we can remove a rib. That's not a problem, if necessary. If a tumor is involving the heart, we can't remove the heart. Those are tumors that we can't treat surgically. And stage 4 tumors, these are tumors with just means they have distant metastases, distant spread out of the chest. And those are the worst actors. Next slide, please. So, along with staging, this is another reason why we stage. To tell people how well people with this kind of stage do. So, some of these stages in the newer staging systems are a little bit complicated. It's been subdivided to 1A, 1B, 2A, 2B. And the whole purpose is to see how people do with those lung cancers. If you look at this as 100% of alive at the beginning of time, of this time point, and this is the years. So somebody with early stage 1 lung cancer who gets treated appropriately and everything goes fine, 80% of those will be alive at 5 years. Whereas the opposite extreme, people with metastases from lung cancer, 40% of them will be alive at 1 year. At 5 years, nobody's going to be alive in that group. So, and then the rest of the stages sort of vary in between. And this sort of guides us into what we tell people and what people should know in general when it comes to getting the treatment and how aggressive to be with the treatment. Next slide, please.